My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. Welcome to this episode of Operate with Zen. I'm here today with good friend and colleague, Dr. Brian Lane. Brian, introduce yourself to the audience.
Hi, I'm Brian Lane. I'm originally from the East Coast, from New Jersey, and then I am a Midwest transplant. I've been in Grand Rapids, Michigan for about 15 years. I'm a urologic oncology surgeon like you, Phil, and that's how we've gotten to know each other, and I've really enjoyed it.
Yeah, Brian and I have spent a lot of time and a lot of projects together over the last, more than a decade now, Brian.
Yep.
And always been super impressed with Brian's academic work, the effort he puts in, and that's how we really hit it off, taking over some big projects together and putting in a lot of time and effort together. But I've also been super impressed, Brian, with your life's journey, and it's had, we all have peaks and valleys, and you've had some valleys that have been challenging and more challenging than some of us others have dealt with. So, if you don't mind, let's get right to that, Brian. Tell us a little bit about your personal health story and what's going on with you today.
Yeah, so I have metastatic myxoid liposarcoma, a diagnosis given to me in January of 2021. But things started before that. We could talk about that as well. Back in 2018, when I was actually at age 44, diagnosed with two different types of cancer.
Yeah, let's start at the beginning, Brian. Bring us back to, a cancer surgeon now all of a sudden dealing with your own cancer diagnosis. Tell us how that story played out, and we'll start getting into your mindset, what you remember then, and go from there.
So I was working out pretty consistently, and I was really focused on my personal health, and I think it kind of fits with a lot of the topics you discussed on this podcast, and really working on my sleep, working on my stress, trying to get in a consistent exercise pattern. And so I was going to the gym and five days, maybe 6 days a week, and doing some of that kind of like heart rate therapy, Orange Fitness and all that, and peak zones. Um, and so I was noticing that I could not sprint, and something would happen in my leg if I sprinted. And I started thinking, I'm just old, and no one in their 40s is supposed to sprint. And I was working with some personal trainers and just trying to figure out what's my current ability set. And then I noticed there was this lump in my right upper thigh, and I felt it. I was looking at notes. I felt it July 30, 2018, and I knew there was a problem. And I thought it was just like an enlarged lymph node, and I felt it. And like, I have friends who are physicians, and my primary care doc, and then my buddy who's our orthopedic oncologist here. And so I had an ultrasound 2 days later, and the craziest aspect is, so I'm lying there on the ultrasound table after completing my first robotic prostatectomy for the day, having this ultrasound being done, and looking at the images myself with the technician and saying, "Oh God, that's not good," and then having her keep me there until the radiologist came into the room and brought me back to his dark reading room to like discuss with me what was going on. And I'm like, I'm fairly confident radiologists don't often do this. And so it was quite a kind of traumatic identification of an 11 centimeter myxoid liposarcoma, and there was like no shame in what he was saying. He wasn't like wishy-washy like we often get on our radiology reports. It was just kind of like, you got to deal with this now.
Wow. I can't imagine that day. And you kind of glossed over this. You said it was your first prostatectomy of the day. So you went back to work.
Yes. So again, deciding whether to put it on the podcast or not. So uh, it's possible that the patient was already in the room while I was receiving this news. And so going to do my second prostatectomy right after getting this news is again probably a good subject of your podcast and what we are used to doing and what we as surgeons, come to expect from ourselves. And that's a that's a big mental hit to get. But I was very able to compartmentalize that information and put it out of my mind and get through the task at hand.
Yeah. I think that's one of those things that, for better or worse, we do get really good at compartmentalizing.
Yep.
Although I think you and I would both probably say in retrospect, if you think you're having a potentially life changing test, maybe do that on a day when you're not
Yeah,
when you're not don't have surgery scheduled.
exactly, exactly. And that's what's interesting. I mean, I by now I often think of myself as Job. I mean, I had so many things happen. Um, but it's like it was just another day, and it's like, well, I can either cancel patients from a clinic or I can cancel a surgery or I mean, I don't have time in my day that works. And if this is the time they're going to schedule me in, great. You want to get me in a couple days versus waiting 2 weeks? For sure, I'm going to come in. But yeah,
Yeah.
interesting situation to be put in.
Yeah. So diagnosed in 2018,
Yep.
you get surgery. Tell
Yeah,
tell us what it's like to be a cancer surgeon undergoing a cancer operation.
it is a mess. It's a complete mess. I think for my sarcoma journey, I have tried very hard to defer to the expertise of my care team. And I think I've done a good job. There are, I remember like thinking through as a surgeon, as a doctor, that doctors are the worst patients. And a nurse once told me, you know what, actually that's not true. Doctors are either the worst or the best patients. And I honestly I'd never even heard that opinion. But then as I started thinking about it, it was like, yeah, I really do want to be the best patient. And I can see how others in this situation can do that. And it's really based on trusting those who are caring for you and acknowledging that they have a more objective perspective than I myself have, and they have more expertise in this area than I have. So I think it's like currently like having a discussion about, oh, should I have a dose reduction on my chemo? Should I, receive my chemo as scheduled on 3 weeks, or should I go to 4 weeks this cycle? Like, I'm the one going to make that decision. Like, where is my medical training um, to address this? It's not there. That's not, what we learned in urology or in fellowship. So I feel like that's been in a real important part of what I do and who I am. And it hasn't been hard for me, um, even as someone who walks around thinking, oh, kidney cancer? Yeah, it's going to be hard for you to get a better opinion than you're going to get from me. But for sarcoma, I'm not that guy. And so that's been easier for me to deal with.
Well, knowing that your journey takes a little bit of a turn after this one, and all of a sudden you
Yeah.
get into an
Yeah.
area where you do have expertise,
Yeah.
take us through the next step
Yeah.
and some of the thought process there.
Yeah. So the next step was a complete mess. So I get my biopsy in August, and I've got myxoid liposarcoma, and so they do staging. So they sent me for a PET CT, and my GU radiologist were like at a meeting. He says, "Hey, can you just come back to my office? I just want to show you your PET CT." And so he's scrolling through it, and he's like, "Oh, look, this is great. You have no metastases. There's nothing." But of course, in classic fashion, my eyes are drawn to my kidneys. And I'm like, oh, what's that? And he's like, yeah, that's why I brought you up here. And so I had an entirely central, I guess initially 3.7 centimeter renal mass that, was like a renal nine, like nightmare kind of like, oh gosh. And so my mind already is not even thinking, oh, I have this. It's more, oh, am I going to do a partial or a radical for that thing? And so this is like this cancer number two superimposed on the first one. Um, and it's just, I don't know, it's just crazy. So anyway, you get genetic testing, you get all this, you do this, but um, to have a renal cancer as a person who on a daily basis makes these decisions was really, I don't know, there were like, I don't know if the word spiritual or philosophical or whatever kind of like, it was just weird. And trying to understand what does this mean for me? Um, what was an interesting space. What ended up happening in my journey was they wanted to give me radiation for my sarcoma first. So I had radiation. Well, then while we were getting that taken care of, I had a biopsy. It showed I had clear cell. And then when I completed my radiation, they wanted time for kind of like the necrosis to act and everything and not go straight to surgery. So I had my kidney surgery first, and then I had my sarcoma surgery after. So I come through this with an apparently localized myxoid liposarcoma and an apparently localized clear cell renal cell carcinoma. And I'm going back to work, a good 3 months or maybe it's 4 months after diagnosis.
Wow, incredible, and I can't imagine the roller coasters you went through. And if you don't mind me asking a little more specifically, so you went from diagnosed with a disease where you're not expert, now
Hmm.
you get diagnosed with a disease where you are expert.
Yep.
And the first one, you said you had no problem kind of giving deference to the docs, trusting their objective perspective, trusting their ability to do this. How did you deal with the renal tumor?
It was a challenge. I think there were I can't remember how many weeks of it was, but it certainly did not go away in a day or two of, staying up at night or waking up at night and just completely thinking like, I don't know what I would do for my patient in this situation. Like, should they have a partial? Should they have a radical? And um, I don't know who else, like what other opinions I want. I don't know how public to go at this point. Um, and it was a real struggle because we had started, and again, I don't know how much to discuss in this, but so we started Music Kidney. So I have this collaborative of all the urologists across the state of Michigan, and we're actually like having virtual tumor board discussions. And so it's like, well, do I want to ask and potentially get the opinion of 20 other urologists on this? And my decision at that time was no. Like, I do not see how having 20 opinions is going to help my mental state at all. And I didn't make it public because I wasn't sure that I would get the same answer if somebody knew it was me versus some other 44-year-old patient. But so I asked about four, maybe 4 or 5 people, hey, can you give me an opinion on a patient? And I asked like 5 buddies without telling them it was me. And that's how I kind of went through and made my decision making. And I think I had a lot of comfort in like who I selected to be my surgeon because I've been in the operating room with the person before. And for this specific situation, I really wanted to make sure it was somebody who would respect the fact that maybe a radical should be done. And I didn't need like the most heroic partial if that was going to be unwise. Like if the eyes said, just take out the kidney, then just do it. And so that's kind of how that decision went for me.
Yeah, it's really interesting. And I think a lot of this is very, very personal. Obviously you sharing your story, but I think if anybody's going through a similar circumstance, personal to the situation they're in, the hospital that they're in, the colleagues around them, I think one of
Yeah.
the real benefits of being a surgeon and being involved in medicine is we do know who the experts are around. We know how to navigate that part of it. So we know when we're getting an opinion, if it's a good opinion or
Right.
not.
Hmm.
Um, but it's still not easy to kind of give up that autonomy and say, okay, yeah, now it's my turn to lay down and let somebody else do this for me, something you do on a multiple times on a daily basis.
Yeah. Yeah. And I think for me, um, I have been really comfortable being in the care of my team locally for my cancer care, for my radiation, for the surgeries I've had that were not urology. But I just didn't feel like having my team involved in my care was fair to them. That decision to me was like, no, I clearly have to go to a different urology place, just for everyone's, benefit in case something went wrong or things like that. But I felt really comfort. I remember, going to sleep that, and I've had 4 cancer surgeries by now, never really being nervous or anxious. It's like they're well thought out decisions. They're well-intentioned surgeons who know me personally and who I consider to be expert. And so that's never been particularly stressful for me.
Yeah. Well, kudos to you, Brian. And I have a very strong family history of prostate cancer, and I've had a bunch of workups and such. And haven't had to go down that road yet, but have gone through that mental exercise multiple times. And we know there's not like one person in the world who's the only person to go to. There are great people all over who do great surgery. And how do you find that person, find the right place, not offend the people in your own institution? All of that is really tough.
Yep. Yep.
Um,
I've, for years, I discussed in my family, and then anyone who's, just asking, hey, you're a doctor, can I just get an opinion? I frequently use terminology like, hey, if you're going to have a surgeon take care of your problem, the person needs to be expert at surgery. If he's a jerk, if she's a jerk, you know what? You might tolerate that because your relationship with this person is like time limited and there's a task at hand and the skills are the most important. Now, if that person's your primary care physician, that person cannot be involved with your care. I mean, the relationship and the trust and the understanding, that's the primary goal there. And so you would not tolerate a poor relationship in that setting. So I think that's clearly true, but I think this is really nuanced discussion. But again, in my case, I know the surgeons who, if I need somebody to do something that's heroic and crazy, like these are the people that I want my patients with. But then I know other people who are just kind of like, look, if it's that heroic, we're not going to do that. Like, we're just going to do the thing that works, even if that means making an open incision versus doing minimally invasive surgery or whatever it is. And it depends case to case. And then there's like standard stuff. So like, if I this may come out as disrespectful to my buddy and my orthopedic oncologist, but when he tells me, oh yeah, we just got to make an incision, cut this out, and maybe we'll take a little bit of muscle on either side, it's no big deal. Like, you don't need the number one surgeon in the world to do something that's going to be relatively straightforward. And we have a lot of knowledge that goes into that, but the general public obviously doesn't.
yeah. And knowledge can be scary sometimes too, because
Yeah,
I'm sure you start playing a lot of mind games and thinking through all of those things. But
yeah,
I think you highlight on some really important things. It's confidence in your team. It's trust, finding people you trust and people who can have an objective perspective, even when they know you personally.
yes, yep, yeah.
So at this point, Brian, 2 surgeries down, 2 cancers, things are good.
Things are good. Things are good for over 2 years. And we touched base on talking about this. Being a cancer physician, once you're a cancer patient, is a really wonderful thing. Like, I have had perspective that I clearly did not have when it was me on this side of the discussion and the patient on the other. Like, once it's really not a us and them, once it's really an us discussion, it changes things dramatically. So, like, one of the things that I've talked about was just like on scheduling selectivity. Like, I could say, oh yeah, I thought about cancer different once I had it. Well, in what way? Well, I would see patients on my schedule and it would be like renal lesion from a primary care physician. And then I would like click open the imaging and I'd be like, yeah, it's a renal cyst. Like, one, why is this soaking up time on my schedule? Two, why was this urgently put in? Um, but what I've really learned is the absolute worst time in a patient's life is that uncertain stretch between, do I have cancer? Am I going to die? Like, what's going on with me? And being given information. And so those visits and the urgency of those visits, I now think they should rise to the top. I mean, if you've got, you know, someone who's got metastatic disease and has already been told that by another cancer doctor. And the question is, do we do chemo first or surgery first, or what are we going to do? Yeah, that's pressing. Like, I understand that's, like oncologically a more pressing issue, but in terms of emotional state and what the patient's going through, that's probably not as urgent a visit as that person who you can tell you don't have cancer. Oh, but my doc said, my primary care doc or the emergency room doc said this is cancer. No, actually, we're not sure. Or no, it's really not cancer. Like, those are such high value conversations, and the amount of benefit we can provide to patients by getting them a timely answer. Um, Again, I don't know. I don't know how many of us would view it that way, but I sure do now. Um, yeah, I don't view those as like a waste of time or anything. I'm like, I'm so glad we got this patient in. Now, admittedly, if we can do some of that without them seeing the physician too, great. But a lot of the times the ball's already been cast. Like, somebody else has already shared misinformation, and so you got to correct the information quickly.
Yeah, and I think this is actually where some of our academic work crosses over, right? And you and I have
Mhm.
spent a fair amount of time and space in this small renal mass realm where illness uncertainty is a major player here,
Yep.
where people come in freaked out. They're told kidneys need to come out immediately, where maybe the complete opposite. A kidney
Right.
never needs to come out and can often be watched or managed conservatively for an extended period of time, if not indefinitely and forever. And you're right. The illness uncertainty is a major issue. And I always find talking with patients is being as concrete and specific as possible helps
Mhm.
with that uncertainty, even if
Yep.
it's not good news,
Yep.
right? Say,
Yep.
this is what's going on. This is our plan. This is what we know. This is what we don't know. Here's steps A, B, and C. Whether they're, we know A and B are correct. We don't know what happens when we get to C or D, but trying to be as definitive as possible, I think really helps people because you're right. The uncertainty is so challenging.
Yeah. I think, and I think the two things. So the prostate cancer space, when I started, now that we have some gray hair and we used to not, but we do now, we lived in this time that
At least you
everybody,
have hair,
yeah,
Brian, which is nice.
ah, there's been times when I haven't, but touche. Everyone needed treatment. And like, when I did my residency training, everyone needs treatment for prostate cancer. And like, to be at this point and be like, what on earth were we thinking? Active surveillance is clearly the correct answer for, if not the majority, potentially the majority of patients with a new diagnosis of prostate cancer. And now the same thing with renal cancer. But no one wants to talk to the patient who's scared and concerned and wants everything done and say, we don't need to do anything. There's in the hospital system or in the medical system, um, that has to be acknowledged for some patients. There's really coming face to face with their anxiety and pointing out, you're too worried or you're over anxious about this. And I understand that. And that's normal and that's common. But really, surveillance is the right thing for you. Um, so one is, how do you go to no treatment versus treatment? And then the second one is the whole life expectancy thing. Now that's a mess because no one wants to be told, hey, I think according to this calculator, you are, on average going to live 7 more years, or however you want to word that. Like, I think, someone in their mid 70s, the average life expectancy in this country would be, to mid 80s, but we need to think, how do you feel about that? And so these are tough conversations, but I think they're necessary conversations, and um, that's what we're paid to do. That's what we're called to do. We're called to help people make the best decisions, not just to, be the best surgeon with a knife or a robot.
Yeah. So bring us back to your story now. You're now two cancer surgeries down. You're on top of the world. You're doing well.
Yep. Yep. So
Um,
I'm going on a ski trip, and I just had my surveillance CAT scan. I had actually just convinced them I didn't want them every 3 months anymore. I wanted them every 6 months. It was about 2 years, 2.5 years out. And I get a phone call from my buddy. I'm in the van, and he's like, hey, and I'm like, oh, what's up? It's like Saturday. He's like, well, I got your CAT scan results, and you've got a 7 centimeter mass in your right chest wall. And I'm like, what? Wait, like I had not even like it was so off my mind that when my friend called me, I did not even think it was possibly related to my CAT scan and that he was my cancer doctor. So it was really off my mind. So I was really surprised and blown away. And things moved really fast. So this is January of 2021. And, everyone was talking about, oh, we can get that out of there for you. But then in more staging, it showed I had, and I hate the words. I mean, I've had to my training the worst possible words to hear. So like sarcoma, like I don't just have cancer, I have sarcoma. And then, oh, you have innumerable bone metastases. Like, what patient have I ever read that report or shared those words with and not felt a huge drop in my chest and concern for the patient? And that's what my report showed. So it was not, it was a tough stretch.
I can imagine. How'd you deal with it, Brian? I mean,
I um I have a really good support system. Um my It was a challenge because I don't know how much to share with kids. And at that point I had a 17, 15, and 10-year-old, if I'm getting the timing right. Um, like how much will they understand and how much are they going to be scared? Um, and then my mother was phenomenal. So she basically moved back from Florida to kind of move in with me and take care of me as these decisions were being made and I was starting on chemo. Um, there was a part of me that was very all business, which was, well, this is disturbing news, but clearly I'm young and I want to do everything possible. So let me get all the opinions I can get, and then proceed expeditiously to the care I need. Um, but emotionally, it was just, again, like out of left field. Like 2.5 years earlier, I had this scare. Um, we were aggressive in our treatment. We did the, standard of care treatments. Um, and I did not think this was going to be me. Um, yeah, it's tough.
yeah, that's really tough, Brian. Um, and if you don't mind me asking, because the conversation with kids is a tough one.
Hmm.
And with the age range of your kids, it had to be different conversations.
Right, right.
So how did you don't have to give specific details, but kind of how did you approach that? How did you think about that? Because there are people listening who are either having similar situations, similar conversations, or going to have them.
Yeah. So I would say, let me pull back for 1 second and then go
Yeah.
right at that. So the language that was used with me was, Brian, our medical treatments have advanced. Um, we think that given your diagnosis, standard, uh, we would think someone would live about 2 years. But we're hopeful that with the treatments we have and you're young and healthy, we're hopeful that to have you survive 3 years. So that's the words that were spoken to me. And it's been 2.5 years since then. And I continue to push on the conversation and discuss it, um, because in a way, that type of language is very specific and not like we know as physicians, we don't know. Like no one knows the number of days we have. So I have no idea if someone's going to live 2 years or 3 years or 7 years. I have medians, I have ranges, I have likelihoods, but no one knows that. Um, so the question is, what do I do with those type of numbers for myself? Then what do I do with those type of things for my inner circle? What do I do with those type of numbers for my work situation? What do I do with those type of numbers for people who care about me, but they're not, my closest 5 people? Um, and now you said kids, so let's go to kids. I don't think it's responsible at all in the beginning of something to be like, hey, daddy's got 2 years left to live. I mean, that would be horrendous. Um, So the word choice and the help is, you know, dad's got a significant uh, cancer problem, and it is very possible that this cancer is going to end my life. And I'm going to do all I can because I want to stay around as long as I can. But there's going to be some changes, and dad's going to be going through some chemo, and he's not going to look the same. He's not going to feel as well. And we'll learn more together about how things go. And I think those type of word choices, I mean, you can convey the seriousness or the concern, but also package it with, um, I'm here to help you, and you may need other support as well. And having people you can talk to, trusted people you can talk about your feelings, because it's expected that you're going to have complex feelings about this.
Did you get help for your kids? Formal help?
I did. So there was a great team with Child Life folks, and I more took advice from them specifically on the topics of how to communicate and how to interact with my kids than bringing them into a new relationship with somebody. Um, and I think that was very helpful. I offered them, there's like these summer camp things where kids can go with either kids with cancer or kids with parents with cancer. They sound like they must be like the most loving things in the world and supportive things, and then kids can find peers. My kids had no desire to go. And it was like, I'm not going to force you to do this, even though I could see there would be a lot of benefit to it. They had their own two or at different times, all three of them have had their own support systems in place. And so we just kind of leaned on those. And I tried to give a commentary or input from the child life specialist.
I think that's good advice for people, and I think can be generalized to a variety of
Yeah.
situations, and I
Yeah.
think helpful.
I would say for anything you're going through in your life and your kids are going through in their life, I mean, the bottom line is every kid needs at least one adult that they can trust and have a good conversation with. And I think the studies say two or three, and I don't feel that has to be two parents. I mean, ideally, that would be two of the three people, but um, I think the evidence is out there for teens and teen at risk behavior, as long as they have somebody, it could be a teacher, it could be a coach, it could be a counselor. And so I've been very supportive to each of my kids and in all these situations. Like, I'm not sure that I'm the best person to talk with my kids about, hey, your dad's dying. How does that make you feel? It's probably easier for them to talk to a third party.
How has this changed, or has it changed your conversation with patients now who are facing these kind of not the small renal mass now?
Yeah, yeah, yeah. So I initially, and there's days when it still happens, have a little difficulty with these conversations. I have to admit, when I see a little bit of too much of me in the situation, uh, those are nights where I'm going home at night saying, "Why am I doing this again? Like, why am I seeing complex cancer patients?" Um, but my view is I really, with some of them, I'll share a bit of my journey as it's appropriate. Others, it just never comes up. Others already know my journey because it's been public. Um, but I think what matters is different than what the surgeon thinks matters. As urologic oncologists, we sometimes do a good job of being uh, cancer physicians and really having a passion for the multidisciplinary care. But often our passion is really, I want to do a good surgery for you and I want to do the best I can. And is surgery appropriate for you? And if it is, I'm going to do the best I can. Um, Having the best surgery and getting out of the hospital in 1 day versus 2 or 3 days, or having a 2 week recovery versus a 4 week recovery is really not the primary issue for someone who's got metastatic cancer and may have a limited life expectancy. Now, getting them out of the hospital and getting them back on their feet quickly is really important, and minimally invasive surgery is important. So let me not say that. But in terms of my conversations, it is like, hey, how are you doing with your quality of life? Where are your priorities? um, we have these conversations all the time, like, well, should I have my surgery before or after this family wedding that I have to go to. And, those are real important discussions and decisions. And it's not always the same answer, which I think frequently is go to the wedding and then have your surgery. But occasionally you have to say, I think this is really, really timely and concerning, and we need to do something now. So I don't know, I have a greater empathy for someone who may view their whole life differently than my assumption. My assumption is you've got a bad cancer. Clearly, you want the best treatment you can and you want it now. And if you say, can we delay a week? I'm thinking you're crazy, right? That's not productive, and it's not really understanding where that patient's coming from.
Yeah, it took me quite a few years to evolve to this, but one of the things I talk to patients about now is to say, listen, the whole reason we treat cancer is so that people can do the things they enjoy doing.
Yes.
And we need to take that into account as we make decisions about what's the right treatment for you, what's the timing of that treatment. And that's a very open-ended kind of discussion. And they'll often take it in a variety of directions. And I think that's, as I said, it took me a long time to get to that discussion, but I think that framework has helped me, and I hope has helped my patients be a little bit more open-minded and help prioritize the things that are important when the prognosis is good and when the prognosis is less than good.
Right. Yeah, no, for sure. I think, like you're saying, like I have in my mind, like when a cystectomy should be booked, when an IVC thrombus should be booked versus when, a prostatectomy for high volume 3+4 cancer needs to be booked. But that doesn't necessarily jive with what each patient is thinking, and how they're going about things.
Yeah.
So, yeah.
So you made the decision to stay at work and to
Mhm.
keep working hard, actually. And
Yeah.
I give you a lot of
Yeah.
credit for that. You've done a tremendous amount of really important things over the last 2 years since this second kind of diagnosis. Talk us through that decision, because there are definitely people who would, you know, put medicine to the side, put the
Yeah.
academic work to the side, and that was not your choice. So talk
Yeah.
us through that decision process.
Yeah. I think I certainly went through very deep soul searching, and an assessment of like, what are my priorities? And I would have said before all my cancer diagnoses, I love my life and this is what I want to do. Like, I want family, and I want to do valuable work, and help people. And that gives me a lot of personal satisfaction. And I don't know that I would travel the world, and just drop everything. And now here I am with my cancer diagnosis, and the question is, well, what do I do now? And it has largely supported that. Um, Things that have changed, and have become clear in my prioritization is I was working a lot. And so working that much means you're making sacrifices, and you only have 24 hours, 7 days a week. And so that clearly needed to go down. Um, and then I needed to prioritize my personal health to the top. Um, as a young, healthy surgeon, you can decide to skip meals, or you can decide to, you know, not get the sleep you really need. But I can't do that anymore. So that needs to be at the top, so that I can actually be there for the people I love. And so then giving my family, giving my kids every last bit of me that they can have and that they would choose to have. And then in my situation, that left more time. Maybe if I had 2 and 4 year olds at home, I would just be a home daddy. But having teens who don't especially want to be with their father 24/7, there's only so much time that we would be together. And so for me, I'm contracted for half time, and being able to have significant flexibility in my work schedule, around my treatments and around feeling well and not feeling well. My current position has me doing research and meetings and administrative stuff 60% of the time, and I'm only officially, uh, my FTE assignment is one clinical day per week. So I think it's very manageable. But for me, it's really satisfying. Um, I think if I were home and just thinking through, do I want to put a fifth comic book on my wall? Uh, you know, that just doesn't seem like it would be a satisfying day. Do I want to get through 5 episodes on Netflix versus two? Um, and I think what I do at work is very meaningful, and I feel I still have the ability to help people, and so that's why I do it.
It's incredible, Brian. And I think that's a really important thing for people to hear who get a great deal of fulfillment out of surgery and caring for patients and who work really hard is that you don't need to put in 120 hours a week to get
Right,
fulfillment out of being a surgeon.
right, true. Yeah. Yeah, I let me say back what you just said, because I for sure, I would be in my clinics and I would have my two robots booked, and someone would come in with the, big renal mass, and I'd say, put them on and let's just do three. And so my mantra was always, we just got to take care of as many patients, and I'm going to, save the world. And that's too much burden for any one person to take. It's not true. There is a system in place. There's other people who can help, but we are in an overload state, but we need to set boundaries. And I will not be your poster child for having been the best boundary setter in the past, but when you get a wake up call, it certainly does that. And the other thing physically is I just can't do it. So like when it gets to hour 7 on a day, I'm starting to drag. And as if your typical day is starting at 4, 5, 6 a.m. and ending at 5, 6 p.m., I mean, that's 12 hours. And I just, so take 4 hours back on that and you're thinking 2 or 3 p.m., I'm like done.
Yeah.
So, yeah.
And I think it's a fair point as we all think about kind of the sustainability, of our careers and keeping this up and getting true enjoyment and fulfillment out of it.
Yeah.
I know faith has been a big part of your process too, Brian. Talk us a little bit through your faith and what faith has kind of done for you and helped you through this journey.
Yeah, so I'm a Christian. My faith has been really important to me way back to college time. And have felt through how many years is this by now? I don't know, 30 years of this journey that a relationship with God is really important. Um, to to feel and know that there is somebody who cares about me, that things are not chaotic in the world. There's a purpose to life. Um, I think this last 6 years has been a real challenge to my faith, a real challenge to how I view myself, how I view the world, how I view God. But I think um, you're either going to spend your days living or spend your days dying. And clearly, spending your days living is the way to do it. There either is purpose to life or there's not. And I choose to believe there's purpose to life. And if that's the case, then I need to live in that way and be purposeful about it. So in my best days, I feel very supported and feel very much, regardless of what other human interaction I have, uh, my faith has really carried me through. In my worst days, my personal faith alone has been insufficient. Like relationships with people are absolutely key. And it's hard. It's really hard. Like, so I have my chemo bag on now. I just got chemo 3 hours ago. And it's like, am I ready for a nap? Am I ready? Do I really have to make myself dinner? Like, it's, I don't know. So, my faith journey increasingly is seeing the good in others, uh, seeing their good intentions, seeing their good actions, um, and really being a part of community and not just I'm in a big receive phase. Like it's been easy for people to be like, oh my gosh, Brian's in such an awful situation. What can I do? But really trying to keep my eye on what can I do for others? How can I be a positive influence um, in the world that each day I would make a difference? And yeah, that's been really important for me.
It's such a great message, Brian. And I mean, I was just jotting down so many amazing things you just said, and I want to walk through some of them with you a little bit. I think, no matter what your faith is, finding purpose and understanding that there, while there is chaos in the universe, and you and I can nerd out on
Mhm,
that a little bit if we want to, but
yeah.
well, there is meaning to what we do, and we can leave this place better than the way we found it, is a tremendously powerful message. And I think what drew so many of us into medicine and into surgery in the first
Yeah.
place. And yeah, obviously we've all had, bad times in the operating room, and things have not always gone the way we wanted them to for every single patient. But in
Mhm,
general, the vast majority of people we influence do better than before they met us.
mhm. Yep. Yeah, and we're really privileged, and that's why I love our career. I now interact with a lot of oncology physicians, and as urologists, it's very different. Most of our cancer patients do really well, versus the oncologist, most of their patients do not very well. And there is significant job satisfaction that we are privileged to have because we can go in there and cut someone's cancer out and it probably won't come back. The other thing I was thinking through is we've discussed, and I've heard on the podcast too, this whole thing about, setting an intention. So I used to, um, there was a good stretch I went where I would pray before every surgery. And what I thought was really powerful was I was recognizing that I'm not fully in control, and that ultimately God has control over what's going to happen. But what I've really come to appreciate in thinking through this setting an intention, um, and I've done this more recently, is involving the entire room in the situation. I don't think it's optimal for me to defer or to acknowledge humbly that God's in control. And then there's a whole five or six other people who are not even a part of the situation. I think it's a much more powerful thing to walk into a room and say, hey, we're going to do our best. And, we obviously all want the same thing. We want the best outcome for this patient. Um, and whether or not others want to invoke God or not into the conversation, about the bottom line is ultimately we are not responsible for how this is going to go. Um, we're responsible to do our best, and we have a lot to do with how well it's going to go. But occasionally someone has an air embolism. Occasionally somebody has an anaphylactic reaction. Sometimes they have horrific bleeding and um, I don't know. So I really have adopted and changed from a me discussion and setting my mind to an us discussion and setting our minds.
I love that, the me to the us discussion. And I think it's just so important to highlight, no matter what your faith is, no matter what your background is or what your beliefs
Yeah.
are, the commonality in our faiths is that
Mhm.
it does help us set intention, it helps us set purpose, and it helps us be in the moment.
Yes.
Whether you're praying at the Wailing Wall or at Mecca, or you have a completely different faith,
Right.
we're all trying to be in the moment together and do the best we can. And I think it's
Correct.
such a strong message, Brian, and it's one I've written down several times now, kind of as we've talked through that. And I love also the existential step or the transcendental step of going from me, I'm setting the intention, to we are
Mhm.
setting the intention.
Mhm.
And I think it is a really important thing that we can set goals as a group, we can set goals as a team. And as you said,
Mhm.
recognizing people may come at it from different angles, but that's the strength of the team,
Yep.
is that, Joe is thinking different than Larry, is thinking different than Stephanie, but we're all working towards the same goal and giving it our best efforts. Such a strong
Yeah.
message.
Yep. Yeah. And I appreciate again the work that you're putting in, and hopefully that the word's getting out about these topics, because obviously historically there's, every ship needs one sailor and, one captain and all kinds of stuff. And I clearly have stated before that not everybody is equal in the operating room, and not everybody is equal in the operating room, but everybody is an important part of the team and is on the team and needs to be. It doesn't need to be. It's better when we are all on the same place.
Yeah,
Yeah.
absolutely. It's so funny. I mean, literally earlier today, Brian, I was doing a multi-team surgery, and great surgeon, good colleague, good friend,
Mhm.
and ran his portion of the operation like I ran my portion of the operation 10 years ago.
Right.
And it
Hmm.
was just a totally different vibe. You could see the way everybody changed in the operating room. And I wouldn't necessarily say that it was wrong,
Hmm.
but I would
Right.
say there's an evolution in the way we operate and the way we operate together. And you can get to the same outcomes in a much kinder, thoughtful, intentional way.
Yeah. Yep. Yes. Agreed.
One of the other things you said was that life does have a purpose, and one of my recent favorite kind of philosophies or kind of things to ponder is a philosopher named Adler, who was a contemporary with Freud, who said life is meaningless, and he didn't mean it that there's kind of no meaning in life. Is that we assign the meaning, we assign the purpose to it, right? There's not necessarily, written down that we get an envelope when we turn 13 years old and it tells us, what we're going to do with our lives. We assign the meaning and the purpose, and we have to have the courage and the strength to find out what that purpose is and seek it. So I wanted to talk to you a little bit about purpose.
Hmm.
And you've made some incredible contributions to our field. You've taken care of a tremendous amount of people. You're a tremendous surgeon. How did you find purpose, and how did that interact with this diagnosis and this journey?
Hmm.
That's a tough one. I'm sorry. That's
It's
a
a
bit
tough
of
one.
a
No, you're fine. So I will tell you, so when I was a kid, I my dream was to be in school as long as possible. I thought I was going to be brilliant and I wanted to win a Nobel Prize. So I was all about, and I think in retrospect, looking back, I think there's a lot of pride in that, and a lot of stuff that there's positives in that in terms of motivation, and wanting to pursue excellence and do my best. But there's a lot that's not perfect in that. Through my training and academic journey, I became kind of disenfranchised with just proving truth for truth's sake, or for getting more grant money or something. Like I really wanted things to help people. And whatever my contribution, I really wanted to see tangible evidence that people were being helped. And so by the time I was deciding about the trajectory of my career, about whether to go to an academic institution or kind of a hybrid situation, I really gelled with a hybrid situation. Sorry, this may be disparate from you or some other academic colleagues. Like I saw a lot of academic urology positions as not really primarily focused on patient care and doing high volume and high impact and high helping people. There was a lot of additional time that I'm not sure that I perceived would be high value for me, or that I would really appreciate all the meetings and all that stuff. So I was really pleased with the choice that I made then. But what's true then is still true today. I've always said, like, if we only help the patients in the rooms in front of us, that to me isn't satisfying enough. Like, I really want to make a global contribution so that for decades to come, or however long to come, when patients have kidney cancer, when patients have prostate cancer, there will be contributions I've made that will affect the care they receive for years to come. I mean, I think the two of us, there's other names that we could include as well, Uzo and others, for active surveillance for renal cell. But I mean, we will have made significant impact here, and lots of lives will be helped. Patients who did not go to unnecessary surgery and have, poor outcomes and things like that. So, purpose to me is to serve the greater good, to serve people. And, if my career ends with I've done, 2,000 great prostatectomies and 5,000 great surgeries, then those 5,000 people have been helped. That is important. And that I feel very good about that contribution. But for me, it really has been beyond that. What's a more lasting um, impact, again, while we're talking professionally?
I think it's incredible, Brian. And once again, I give you credit. You've been an inspiration to me before the cancer journey started, and continues through that. So I kind of want to thank you for that. We're getting to the point where we're almost at an hour. I want to give you the opportunity. What didn't we cover? What do you want to talk about? What do you want the audience to know about and think about as they move forward after listening to us today?
I really appreciate the opportunity to dialogue with you. And I think there's several parts that should um, inform where a lot of us will be. you're seeing cancer patients. There's someone in your life who has cancer. You get cancer. How do I think through my professional life? Um, I think the things now that are a challenge for me are I'm 2.5 years into this, um, almost 5 years from my initial diagnosis. I have set goals for myself, if you can call them that, of I want to make this 3 years, and I want to turn 50. Uh, and the challenges that I really face are, do you make a 5 year plan? Do you make a 1 year plan? Do you make a 6 month plan? It's really challenging on a daily basis, um, to try to decide how far ahead to look, um, and what decisions do you make, in light of that. So that's something I struggle with. I think, communication's really important. Um, I think transparency is huge, but the where my personal life, and my professional life and my family life interact, um, there's just so much uncertainty. And so like I had a meeting last week with my employer, right? And they're like, "What's your 2024 plan?" How can we make a 2024 plan if I'm not telling you what's with my cancer situation? Like, all the employment laws, all the whatever, that conversation has to be one that is covering topics that I'm fairly confident they cannot ask me about. Um, but these are the kind of things that are just, I don't know. No one wants to be on disability. No one wants to be disabled. Everyone wants to work. But, figuring out what are my limitations, figuring out what's healthy for me, what's best for me, what's satisfying, what's purposeful, like we've discussed, and then figure, you know, I talked about it early. Like, I would love to go on a boat and cross the Atlantic. Like, I would love to do some world crazy traveling. The thing that probably limits me the most is I don't want to leave my kids behind. And so I've chosen shorter adventures than something like that. Um, but like, how do you factor that stuff in? These kind of things that I think would be fantastic to do. But balancing that, like I said, personal, family, professional. And so I know I have some great trips coming up actually this month, and I'm looking forward to that. But um, that's kind of where I'm at these days.
That's awesome, Brian. Um, well, I want to thank you for spending the time with us and being so honest and open. This is not an easy story to tell. It's not an easy story to talk about. And you and I have kind of had this conversation before, honestly, not quite to this depth. And it's been a great challenge kind of getting through this hour with you. And I think
Yeah,
part of that is that we both desperately want to help people beyond our sphere, beyond our direct sphere of influence.
right.
And I know having this conversation today will extend that sphere and help in that conversation.
I appreciate that. What I think something that might be a good lighter way to end this. So I went to the AUA two times ago, whatever that is. So 14, 15 months ago. And I remember quite literally walking around and talking and interacting with people, thinking this may be my last time that I would see them. And it was very challenging, which to say that. But what I learned at that time was I really shifted my focus to, I used to want to partner with you and with others and be a part of, the great thinkers and the great changes we could make. And I got to the point where I don't want to do any, or I don't want to do this by myself, and I can't do it by myself. It's so much better. If you want to get somewhere fast, you go alone, and if you want to, get somewhere far, and you got to go as a team. Um, and so I was really passing the baton, 15 months ago. And then I came back to AUA 2, 3 months ago, and it's like my chemo's not beating me up as much. I'm still here. I'm like, and it was a very different interaction. And so living in this space where I'm feeling pretty good, and interacting with folks and seeing folks and trying to figure out what does this next year hold, has been pretty awesome, and interesting just to see. Who knows? Maybe we'll talk again in a year.
Yeah, I think we should
Yeah,
schedule this annually.
yeah. There you go.
Well, Brian, I just want to highlight some of the amazing things you said today. Our conversation went all over the place. It started with your initial cancer diagnosis. We talked about how doctors can be either the worst or the best patients, and some of the ways we can be the best patients by trusting our team, trusting their objective perspective when we know we can't totally be objective when it comes down to ourselves. We talked about the perspective that having a cancer diagnosis or a cancer scare or whatever it may be can give you, and that the absolute worst time for a patient is not being told that they have cancer. It's the uncertainty, the time leading up to that where you know nothing. And hopefully that resonates with people and gives them a little more grace for the patients who don't have a cancer that just want to get into your clinic to see you. And I think it is a valuable lesson. And we have so many tough conversations. It is really nice every once in a while to be able to say, guess what? You don't have cancer. Go home, have a glass of wine. You know, everything's going to be okay, because a lot of our day we are having different conversations, and that's tough. You talked about your support system, and I really love how you gave us the kind of the target. You started with self, and then you talked about your inner circle and your family, then your work circle, and kind of secondary and tertiary groups of friends and relationships, and how you span that out. And I think that can help give people intention and purpose once again as they go through tough times. Start inner self and kind of work your way out, making sure that you're taking care of the moment and the people around you. And we talked about staying at work and why you did that. And I loved you said, before all of this, I love my life. And so I want to keep loving my life. Family, value at work, value caring for patients, and how it's continued to be truly satisfying for you, even though you're not working as much as you were before all of this started. And lastly, we finished with faith, and we talked about your faith, but we talked about kind of faith in general. And I think one of the really important things you said that what helped you through all of this is faith and relationships. It was the ability to receive and to give to others, even when you were in your toughest moments. And I think that is incredibly powerful. And so I want to thank you once again, Brian. This was an awesome conversation. I know there's a ton of people who are going to benefit from it. I know I did. And I look forward to talking to you again and seeing you in person, my friend.
Thanks for having me, Phil. This was great to do.